Hi. So I'm Dr. Kareem, and basically the object of making this video is to show you all how we make records in this office. These are mainly for this video is mainly for my students, physicians who come from abroad and want to help us and also learn at the same time as observers. So let me start by saying a few rules of making records that have been used, that I've seen being used all these years in different hospital settings, and how program directors expect you to do the same when you get your residency. Rule number one is you write your own narrative as in your own words as much as possible and as good an English as you can use and follow the rules of syntax and full stops and capitals and other things. Write in upper and lower case, never write in uppercase, all uppercase, because that's not considered to be polite in this country. Number two, use of abbreviations. Avoid the use of abbreviations as much as possible. Several years ago, hospitals made it a rule that no doctor is going to use abbreviations when writing history and physicals, consult notes, or orders, especially orders. And let me tell you why. Because abbreviations can be misleading, can be confused with, uh, with one thing for another. For example, a doctor used to write in the old days, in the early in the 80s and 90s, when I was practicing in many different hospitals. There was no computers, there was no electronic uh, prescriptions. Physicians had to write down on an order sheet whatever they wanted, and the nurse would take down those orders and then send them to the pharmacy. And that's how things got done on the wards. So, for example, if the patient wanted to prescribe more magnesium sulfate, he would write MS 1 gram to be given this stat or whatever. Well, guess what? Because if some nurse was new and a student nurse and didn't know what MS was, she looked it up and maybe found that MS was morphine sulfate. Imagine that she's running around asking the pharmacist how can she get a 1 gram dose of morphine sulfate for the patient. Thank God the pharmacist would intervene and not let her do harm to the patient. And that's just one example. So many other examples, because another consultant would come and patient, somebody wrote a consult note that patient with HTN, CHF, MS, and IBD comes in for as a new patient from the in the emergency. Or I will spend half my time trying to interpret what IBD means. So avoid that. So write the whole thing: congestive heart failure, inflammatory bowel disease, or hypertension, not HTN, diabetes mellitus, insulin dependent or maturity onset, so forth. So that's a rule. Now I'll give you other rules as we go along, but let me tell you what I'm going to do today. I'm going to show you how to write three different notes. Note number one, cardiology consult of a new patient, a new cardiology consult. Note number two, a follow-up of a cardiology patient. Number three, internal medicine note, for example, for a disability patient. Now, 99 over 98% of my notes will be either new patient cardiovascular consult or a follow-up cardiology. Very rarely, maybe once, 2 or 3 times a week, I would get a disability patient who comes in, and that note is an internal medicine full note, not a cardiology note. So it's a little different. So that's three different types of notes. New patient cardiology consultation has a questionnaire that looks like this. The patient fills out the questionnaire in its entirety, and he tells you what his concerns are and gives you all kinds of history like the medications, family history, marital status, social history, habits, and then a review of system is outlined into that form. It's a 5-page form that the patient fills out. You're going to refer to this form when doing your review of systems, the very important form. So that's one. So for the internal medicine, it's different. For cardiology consult, it's different. So there are two different questionnaires. Next form that we have is called, I call it my follow-up progress note cheat sheet, which either you or the medical assistant will fill out. So we ask these questions and have these check boxes so that we don't forget to ask the patient. And it starts with the general follow-up note, and then chest pains, shortness of breath, and why the patient is visiting, etc., and ends with patient needs refills of medication. So this form is used for the follow-up and is exactly the way the Practice Fusion, that's the program that we use for writing notes, it's called Practice Fusion, exactly the same way the Practice Fusion is written, so or constructed, so that it's easy for you to just follow this form and then tick mark on the templates, which I will show you. So that's one thing. And then, of course, we have the super bill. And why is this important? Because this is where I write my orders on the bottom as to what the labs have to be done and what has to be scheduled, and diagnosis codes. The common ones that I use are ticked off here, are circled here, and then you can use these diagnosis codes to put in the Practice Fusion. Then there is a worksheet for a follow-up, which gives you the vital signs, and you write your handwritten notes here. And then you use this form for doing the computer notes. So these are the forms which, of course, you have to look at them. I can't show it to you here, but you have to look at them in the office, and my medical assistant, Erica or Debbie will show you these forms, or Liz will show you these forms. So let's get back to, I'm going to share the screen with you, and I will show you how the Practice Fusion is run and how we record these things. So let me share the screen now, and I will go to the site, and the screen will be here. And let me get to the actual notes here, and we go here. So you have your own login into this Practice Fusion. So once you log in, and of course, Erica or somebody will show you your own login, which you should destroy when you leave this office. So you do not ever sign into this program once you get out of this office at the end of your rotation. It's illegal to do that. And we, most of the time, we change these codes, change these passwords so that you will not be able to access it. And even if you go on your computer and try to access it, it won't let you do it anyway without informing me. And if you do that, then of course I will be very upset, and we'll have to question you as to what was the need for you to look into a program. Once you are done, you don't have any business looking into any of the patient's records or taking any record with you, because that's against the HIPAA law here, is patient privacy. Whatever you write here, whatever you learn here on the patient's chart, on any particular patient, remains in this office. If you know the patient socially, if you meet the patient later on, you cannot, I repeat, discuss any medical records with the patient or their relatives or anybody, or even your own relatives or own spouse even. This is the strict rule about HIPAA for which I'm responsible, and I take you in this rotation on the honor system that you will abide by this rule all your life, and do not take anything, or even our forms are all copyrighted, and you cannot share it with any other practice or any other thing. You can share the knowledge that I impart, or whatever you learn here, that belongs to you. You can use it for patient care, and that'll make me happy. But as far as proprietary information, proprietary methods, patients, my practice, our practice over here, what we do here, all these are proprietary, and as a observer, you can just observe, but do not take it with you or share with anybody. Thank you very much. So let me get to the real information that I want to show you, to discuss with you. I've created a patient called Don Lee as an example to write whatever we want to write on this patient. So how do you pull up Don Lee? You go to charts, then you go to patient list, which is already here, and you write down Lee or last name or first name, and you go to Don Lee. Don Lee is my pet also, so he's a little pet donkey. So he doesn't mind whatever diagnosis I give him. He's okay with that. So what we do now is let's start with a new patient. So this is a new encounter, and you click on it, a new encounter. Now, one thing I want you to absolutely remember is that there are two little boxes here. One is a seen by and one is a facility. Facility will always be Amin H. Karim because I'm the only one that has this program in this office. But this seen by will vary. It might give any of these names of my employees and other people who have been here. Make sure you change this to Amin H. Karim because ultimately I'll be if you put Amin H. Karim, then it will come into my box because I have to sign off on all the records that you write in the end. So if it doesn't say Amin H. Karim, it will not come into my record, into my box. So important to remember that. And now let's start with the note. So what you do is you drop down this menu. Now notice this, forget about all these things. Right now you're concerned with subjective, objective assessment and plan. I'm going to show you that. And of course, you will also later on do all these other things like allergies, medications, and all that you can write down later on. But the main things that I want to show you, which need to be understood, are these how to write these notes. Other things are fairly obvious. Anybody can learn that. So subjective. Now in subjective, it brings you to this SOAP note type of setup. In subjective, you click on record, and that opens this window where you start recording. And there, this is a new patient, cardiovascular consult. So you go down to this new patient history and physical, click on that. That gives you both the cardiovascular consult and internal medicine. So the first one is cardiovascular consultation, second one is internal medicine evaluation. Click on the cardiovascular consultation, and there you go. It gives you the entire history in a template form. And all you have to do now is to put meat on it, as we call it, and fill it up. So the first thing you write down is the referral physician. Look at the demographic sheet of the patient that is filled out, or ask the patient who referred the patient, and you write down in this format. Ronald Busher, for example, Buescher, MD. This is how you write it. Do not write Dr. Ronald or Dr. Busher, just write Ronald Busher, MD. History of the present illness. So now you have to write down the history of the present illness, and what do we do there? So first thing you do is you write down some bare facts that you have observed on the patient. Very easy. I mean, you don't have to ask the patient. First is this step, and these are all these written sentences which you click and they come over here. Let's show you here. As soon as you click, it populates this first sentence. Patient presented to the examiner ambulating without assistance and without any device. And that's for patient who walks in. If the patient didn't walk in, then there are other templates to use. For example, he came with a single point cane, or he presented on a wheelchair or a walker, etc. So we are going to say that the normal patient presents like this. And the second sentence that goes on the same line is that history was obtained from the patient who appears to be reliable. That is for a patient who is giving you the history. If it is otherwise, then you state the otherwise, like it was obtained from a member of the staff, a patient who doesn't speak English, somebody interpreted for you, then you put this one. Of course, in a case of a lady, you put down that the member of the staff acted as a chaperone throughout the interview and physical examination. Again, legally important, and you know the reason why. You have to document that. And then you create another second paragraph. Okay, leave one line and create another paragraph. Now you write down why the patient presented. Patient presenting complaint is chest pain, let's say, or shortness of breath, or multiple cardiovascular factors, high blood pressure, and heart beating fast, abnormal EKG, MROs, Fujax, slow heart rate, heart murmur, swelling around the ankles. So these are the most common symptoms that I get. So I wrote it down. I can add more of these, and but if you don't find it here, then type it out. Presenting complaint. So that's your presenting complaint. Actually, in the old days, we used to write this separately and then the history of present illness, but I have modified it slightly. Next paragraph. Now, leave a line and then write down. Now you write your narrative here. The most important part of this whole record is your narrative. Narrative means, in your own words, you write down from the notes that you took while talking to the patient, and you write down just in the classic way that patient is a 50-year-old African American male who presents with history of chest pain. Now, note I didn't write with HX of CP like some interns do. Try to write shorthand. Write the whole thing so that anybody can read it, and then you go on. Now, of course, I won't teach you here. Write what about the chest pain. You write whatever the patient told you, and there you know that you should know a clinical exam what to ask for a chest pain. Just an example, when did it, how long has it been there? When did it start? When do you get it? How long does it last? What relieves it? What aggravates it? What brings it on? What relieves it? Does it stay at one place? Show me with your hand where does it occur in your chest or wherever, or a back or neck or shoulders. Where does it radiate? And what have you done about it so far? So forth. So you get the whole narrative the way the patient told you. Now, with that, of course, there's a cardiovascular exam, so we're going to ask all the relevant questions in like a cardiovascular review of systems. Have you had this pain before? Have you had a procedure done for it? Have you had a history of coronary artery disease? Have you been to the hospital emergency room with this chest pain? Do you get shortness of breath with it? Do you get palpitations? Have you feel dizzy with it? Do you have collapse with it? Have you ever passed out? Do you have shortness of breath when you lay flat? Do you have swelling of the feet? All the relevant cardiovascular questions you ask, just the symptoms. I'm not talking about anything else yet. Symptoms. So once you do all of that, then if you notice that I've written some common scenarios for my own sake. If y'all are not here, then I want to create a shortcut. So I write down pain is, always ask whether the pain is exertional or non-exertional. So I have my own little paragraphs here, which I do for getting it done quickly. But you don't have to follow these paragraphs. You go down to all the way down to for example, patient has a history of coronary artery bypass graft surgery in the past. You can use that paragraph. Is a history of heart murmur, history of bilateral ankle swelling, has shortness of breath on minimal exertion, and then does have orthopnea, PND. See, you have to remember the spelling of PND and all that is all written there. Denies any history of syncope. Remember, this is negative. Denies any history of syncope. That means, remember what they used to teach you? Negatives are also important as positives. So all negative symptoms, which means that there is no such symptom, is important. Patient has not sought any diagnosis. He's come here for the first time, has not seen anybody for it. Maybe he's only seen his GP. Then there is a history of high blood pressure, and the pressure is not adequately controlled. There is no history of diabetes, or there is a history of diabetes, and patient has elevated lipids which are not under treatment, has noticed bilateral ankle swelling. There is no history of calf tenderness. He does have dizziness and lightheadedness, denies fainting or loss of consciousness, has intermittent palpitations, physically active and continues to be employed, and on and on and on. You can read these and write down whatever you think you can put down as a negative, positive, and if you feel that this is relevant, put it down here. There's no harm in putting some negative things like he doesn't have that, so nobody's going to catch you on that. Fair amount of emotional stress lately, was admitted to the hospital, is morbidly obese, or is underweight. A patient has had a stress test, um, history of chronic obstructive lung disease, patient has hypothyroidism, and history of snoring. All these things you can also quickly look at the questionnaire and figure out. No history of rheumatic fever as a child. You know, denies any hallucination. That having done that, then you create another line, and an important topic is cardiovascular risk factors are hypertension, hyperlipidemia, diabetes, tobacco use, advanced age, etc. Sedentary living, male gender. We never write male sex, you write male gender. It's a polite way of stating that. Chronic tobacco use. Having done that, then you create another paragraph and you say, why was the patient referred here? Well, he was referred for surgical clearance or he was referred for evaluation of cardiovascular risk factors. That's it. So now you have done that, okay? You have finished the history, and let me show you. If you look at your what you have done just by clicking, look at the amount of data that you have put in there. That looks like somebody really took time to do a good narrative, although all you have done is click and paste, but those are all complete sentences, so one cannot tell. There are some spelling mistakes which I have to correct. They marked in red, for example, nocturnal is, and this program has automatic corrector, so you can correct these mistakes if you don't mind. And later on, I'll correct it in the template. So here, myocardial, for example. So you correct those mistakes, and then of course, now rest is easy. This is the only part that I have always have trouble with my students. My medical assistant didn't teach them, or has difficulty teaching them. They forget about it. And I forgot to tell you that there is a ring binder on your desk which has such a history all typed, all printed out, and you just look at it and see how that is done, and you'll understand. The rest is easy. Past medical history, you look on the questionnaire, write down surgery, diet, family history, occupation, tobacco, alcohol, caffeine, exercise, all these things. Now, cardiovascular, the review of systems, I have put down patients accept everything in the world. Okay, so you pick and choose now. Patient accepts this, and wherever you feel that is not, it doesn't have this thing, you put down denies. Okay, denies. So wherever you put yes, you write down accepts. Where you put no on the questionnaire, you say deny. So that's the review. That's how review system is done. We used to do it manually or at the time of interview, and had to remember all these little things, then go back and write it down. But luckily, we now have a system where we can, let the patient fill it out for you. And there are also documents. If some patient complain that, oh, I didn't tell you that I have got a urology problem. Why did you get that? So you show them the questionnaire that, you yourself marked it. So having done that, then there are some little questions like in a case of a female, last mammogram, pap test, and last menstrual period. Now remember, this is where some interns, residents get caught. If you're going for these clinical exams, so male patient, then remove the female genital system. So female patient, remove the male system. Don't let both of these go together. It's obvious from there that you're talking about two different sets of symptoms and diseases. So please make sure that you take out what is not relevant here. Okay. Now next you go to objective, which is the physical exam, and here I've created another template for you that fills a normal physical exam. Everything is there, but remember now, this is a very big trap here. And don't put down this normal exam for everybody, because any any examiner or insurance company or Medicare can tell that you're using too many templates and that you're just cutting and pasting and not really examining the patient. So when you have examined the patient, then write down. There are some things that you don't have to really examine. you can look at the patient's skin and you know what the skin looks like. There's an abdominal exam, you can see if it is protuberant or not. Heart exam, always, obviously I'm more interested here. So make sure that if you heard a murmur, that you change that. If you heard a pericardial rub, if your heart sounds are irregular. And also remember the most important thing that a lot of my patients have bypass surgery. So patient, right down in the first line, patient has a midline scar, well healed. Okay, something like that. Or if he has a pacemaker, right now there's a pacemaker in the infraclavicular area. Now, neurological examination, I put down everything, but you don't have, we don't do a complete neuro exam, but you heard the speech, memory, you have tested, you know the orientation, you know his emotional state. Leave those alone because you don't need an exam to go over that. But if you didn't do reflexes and all that and didn't examine the motor system, then all you have to do is highlight it and delete it. Finish. If you didn't examine the femoral pulse, then you can take it out. I don't mind. Popliteal, femoral, take them out. But I'm sure you did the post-tibial dorsalis pedis, radial, brachial you should do. And in both sides, you can take these out. If you did examine them, then leave them. Extremity exam, of course, a joint exam we usually don't do, so don't commit yourself to normal joint exam because the patient may have knee replacement and they will catch you and say, well, you never even looked at the knee. He doesn't have his own knee or hip joint replacement. So take this out. Venous stasis, you can also add down pedal edema here and write down 1 plus 2 plus pedal edema. So that completes your exam. Go to assessment. Now, I only put a few sentences here, a very generic sentence, patient needs further cardio workup, which is the most of the time is true, or patient is not clinically stable and I need to send him to the hospital, okay? And we'll come to this disability later on. Go to the plan, all these plans are listed here, okay? New medication started, then 24-hour monitor, then ultrasound, then treadmill stress test, then cardiac catheterization, whatever you did, write down here, okay? Two-dimensional echo was ordered, chest pain advice was given, okay? All these can be added on to the plan. And then you save it, and then of course when it comes to me, so you don't sign it ever, okay? Because I have to still examine it. Once I sign it, this is the trick of the electronic records. Once you sign it, then you cannot go back to change it. Because if you do change it, then there is an electronic trace of who changed it, who was signed in, and when was change made and what changes were made. That's legal. Just like you go to the chart and you cancel something and write over it, but that creates an altered chart. But in this case, theoretically, you can go and change anything and nobody will know, but that's not the case. Once you sign it, before signing it, yes, I can change it. I can cancel out things or I can add, subtract, whatever. Once I sign it, it becomes permanent record, and then I can only sign it by putting an addendum, which you will see after a complete record. So that completes our new patient. So now let's go to the to the to the timeline. Shows you all the different notes that you have put in there, and if you want to create a new note, you go to new patient encounter. Now I'll do the follow-up. Follow-up is also very easy now since you know the basics. New follow-up, and you say that you want to create a new encounter, and you go again to this subjective record. Now instead of going into this thing, you go to back, and now you're going to select the follow-up notes. Okay, follow now. Remember, I told you there's a cheat sheet of that with the medical assistant, or you will go over in the patient room and click off boxes. Well, you pick up that box, that note, and now you're going to just follow that note, and everything is there. General follow-up statement. Next line will be patient is non-compliant, for example. He denies any chest pain. He continues to have intermittent atypical chest pain. Whatever you wrote down there is here now. Okay, so you go through these sentences are exactly the same order as on the form. Patient has not taken his blood pressure medication, and he's not able to tolerate statin drugs, and he has given up smoking, and he continues to smoke, and he has a flu shot and this and that. So everything is there. Okay, I've not put a COVID shot yet, but I will do that because now we ask every patient. If it's a virtual visit that we did, then we can put down this sentence. If I did a visit on the FaceTime. Objective, again, this is nice little preset exam, but again, remember, don't use this. Put some changes here. Let's say that you patient is obese, you write down obese, or frail. If it's a very old man who is shaking, frail, etc. Okay, or anxious. All right. Jugular venous pressure, I use sometimes write down elevated. Cardiac exam, if you notice anything different, if I told you, look, there is a murmur, you heard it, systolic, diastolic, grade 2 over 6. Lung exam, if there are bilateral crackles. Abdomen, even if you don't put the patient on the exam table and then examine his abdomen, it is easy to see that the abdomen is protuberant, P-R-O-T-U-B-E-R-A, protuberant or flat. Okay, you can see that. Neurological exam, there are no obvious deficits, or patient has weak left side or droop or whatever. Okay, extremity, no clubbing, edema, or there is 1 plus 2 plus edema. So change this one. Okay, 3 plus 3 plus edema. Gait appears to be normal. Yes, if it is normal, but this is the very common mistake I catch. Patient came on a wheelchair, and some resident or even my medical assistant doesn't change this and writes gait appears to be normal. Well, how can it be normal? He is in a wheelchair. You have to be pushed along. Patient in wheelchair. Patient appears. Patient take it out on wheelchair, or gait is slow, or wobbly, or incoordinated, whatever. So describe the gait. And the gait you see when the patient comes out of the room and walking in the corridor, you don't have to make them walk. You just notice it when they come out to sign out. Okay. And whatever other exam features you want to write down, write down. If it is very important, put it in bold letters. Even I don't mind. Whatever you want to do. I'm very liberal as far as how you write it, as long as you write it. Important thing is document it. Okay. Failure to document is more serious than whether it is not in block letters or not in bold print or whatever. But write it. Whatever you wrote on your observation sheet and we discussed it in the room, write it. The same with your. Let me go take you back to this important. Whatever we discussed with the patient. When you hear me talking to the patient and patient is giving you the answers or even telling you a new story or he was admitted, this is where you put it down. You write your little note, reminder, and here, in your own words, write down that what the patient told you. Okay, because that's what the follow-up is meant to be. Now, in the assessment, patient is stable, blood pressure is not under control, patient is in chronic atrial fibrillation, it remains in sinus rhythm, etc., etc. All these little sentences, uh, or he needs to go to the hospital. Then you go to the plan. The plan is a very generic things are there, and there are some specific things, and you should pay attention to them. Just read them once, and then you will know what is here. So, for example, every patient is my habit or whatever you want to call it. I tell them to take a low cholesterol diet. So that's whole, and then leave a line in the next paragraph. New medication started today. Number three, get all the labs from the somebody. Then you do low sodium diet, which I advise everybody. Okay, refill medications if we did that. And patient needs to find a primary care doctor if they don't have one, or if they have one, they were advised to maintain follow-up. Okay, anticoagulation if they are on it. If we give them chest pain advice, you write down. If we started nitroglycerin, if we got a chest X-ray, see everything is here. Whatever we planning, we do. Advice to lose weight. Who doesn't have overweight here? So they all need advice for lose weight, which is all written for you. If I order an echo, then here is an echo. If I order a nuclear stress test, here it is. If it is an abdominal ultrasound, here it is. Okay. And there are some tests I used to do, but don't do it anymore. Holter monitor, of course, we do. I tell them to stop smoking, bilateral carotid ultrasound, etc. Okay. And then COVID-19 vaccination. See, I'm keeping up with this trend. So this I've added that. If you don't have it, then just put it just go to add template item and put it there, and it will show up there. Just maybe bold the first few letters. Once you have done that, everything is done, save it, and that's it, that's your note is written. So I'll quickly go over now. I think you have learned the basics. Quickly go over how to write the DARS patient, which we call it a disability patient, which you get once in a while. And that's a pure internal, this is where I put on my internal medicine hat. As you know, we all have to do internal medicine before you become cardiologist, and you do the complete internal medicine exam. So you go to the timeline and new patient encounter, new encounter, and you do subjective record. And now you go back and go to the same history. This is a new patient, okay? These patients only come to me once and once only. There's no follow-up on these patients. You do this, and instead of choosing cardiovascular, you choose internal medicine evaluation. Again, the same setting. Everything is there. And again, you write down what the patient came in, what the presenting complaint here may not be cardiac. Presenting, you won't believe it. I got all kinds of patients who apply for disability. Patient is depressed. Patient cannot walk. Patient has problems with multiple diseases. And he cannot work. So those are the presenting complaints. And then you write down, narrative is extremely important here because there are no templates for narratives here. You got to write down the whole story in a chronological fashion. What does that mean? Start from the beginning. Patient, for example, I used to do this in my student days. My professors taught me. The best way to begin is patient was in a good state of health till 10 years ago when he had a road traffic accident. He had an accident, he was taken to the hospital, he stayed there for 2 weeks, he had physical therapy rehab, he had to have surgery, he broke his femur, he broke his humerus, he had a head injury, and he could not work for after that, and he recovered, he went back to work, but then he had more problems, etc., etc. So chronologically, you start from the 10 years and then bring it to the present tense, bring it to the present, what is it now? Our patient now is homebound, he cannot work, he's supported by his wife, he does do some chores at home like washing dishes and taking a walk once in a while, but he cannot drive. Write down the patient's state of affairs as they exist. So this is where it is different. You write down the disease part, but also write down the social part. What is he doing now? Who's supporting him? Where does he live? Apartment? Is the apartment on the ground floor, second floor, third floor? Does he have his own house? How does he travel? Um, what does he do in his spare time? Best thing I found is tell the patient to describe a typical day in his life. Gets up in the morning, eats breakfast, watches TV all day long, etc. And then so you describe the whole day. That will give the now. Let me tell you why this is important. These tests these exams that we do, they call the DARS exam. They go to the state of Texas. The state of Texas has a contract with me to do an independent evaluation of these patients. The report I send them is examined by a panel, and the panel decides if the patient gets disability or not. So it is very important. If the panel is not convinced, they won't give the patient disability. If they are convinced, the patient will get disability, and so forth. So I have to be very careful. I have to be very truthful. I have to be very honest. Write down. Do not use. I don't give an opinion, but I write down whatever I find. So if you go through this thing, it's the same thing like any other exam, review of systems, and an objective. Again, internal medicine exam is put as a template. Differences are that we do the eye exam, and the medical assistant will teach you how to put down the results here. Simple, just like any optician does that. And we do the straight leg raising test because most of my patients have back pains. That's why they're disabled. So you do the straight leg raising, which I'll teach you. You do the girth 4 inches above patella, 4 inches below the patella to look for muscle wasting. Cervical exam, neurological exam has to be done as much as possible, including sensations, reflexes, coordination, gait, stance, everything. Gait has to be tested, and I'll show you how to do that. You have to make the patient walk on tiptoe, heels, tandem walking, hop, and squat. Okay, all this complete exam has to be done just once. Assessment. Assessment is assessment for disability. Just put this down. You don't have to do if you want to do it. If you get experience, you can answer all these things, or not answer, but just keep those things as is and write down your own little findings here. That now some patients will have to be sent for X-rays of the back, and you write down the patient will be getting an X-ray and so forth, or get records from the previous evaluation. Or you can do this in the plan. In the plan, you write down. First thing you should do is, we're not going to start medication because we don't treat this patient, but you do put down this note, which I have written as a generic to take myself off the patient's care. In other words, I'm not going to be taking care of his back pain or his whatever. Okay, I'm going to release him back to his doctor. So I write down that I'm not allowed to keep those patients. That's arrangement. I will tell them, go get your own doctor. I'm not your doctor. Only you cannot even call me for emergencies. Go to the emergency room. So I put a disclaimer that I have nothing to do with the patient once he walks out of the office. That takes me off the patient's care. And if you order X-rays, labs, whatever, if they want, they will tell us what to do. I don't do these things unless they tell me. There's a piece of paper they bring with them, and that tells me to do X-ray or MRI, or usually they're not MRI, labs or echo or EKG. So when they tell me that, I do it. They don't tell me, I don't do it. So if an echo is suggested by them, then I put down echo. There you go. Okay. Then I save it, and that's it. Then I leave it there because I have to still go over it, make sure it's all accurate, make sure all the impressions were entered. Rarely I will write down that the patient really doesn't have any disabling kind of problem, that he has a good functional status. You'll be surprised how many times in just questioning them, the patient accepts that, oh yeah, he goes and walking every 2 miles a day, and then they tell me that they are short of breath. How can you go 2 miles a day and they are still short of breath? So a lot of patients have made up a story, and they're advised by somebody to make a story that they will disabled, so they get their disability. Disability means they will get income rest of their life. So, and they will not be required to work anymore. So you have to be careful. But some patients are truly disabled, others are just trying to make up a story, and some of them are very young. So that ends this whole thing, and I'm sure you hopefully you benefit from it. And I'll have the reason I made this so that I don't have to keep repeating it, and my medical assistants don't have to keep telling you. When you all the new people who come in will have to look at this whole tape, I hope, and correct me if I'm wrong, and then ask me questions if there are any questions on this. And of course, main thing is that we learn as we go along because patients are all different. So I hope you have a good time in this practice. Um, just to remind you, remember what I told you, that whatever you learn here, you take it with you, but whatever you observe on patients' charts or records or any other business activities, they remain in this office. You should not utter them anywhere else. I wish you the best, and I wish, of course, you'll get your letter of recommendations whenever the ERA sends me the letter. We will, and make sure that you record your attendance on my book, so I know exactly what dates you were here. Remember your name, and I will give you the reference. And I wish you the best, that you hopefully get a good residency program and achieve your aim. Uh, just on the record, many of my older students have been doing this for last now 35 years. Many of them are now in practice, and they got good residencies. And I'm very pleased to note that. Of course, not everybody was lucky. Those who were long time away from medical school are the ones that end up having issues and not getting interviews. So I wish you the best. Thank you very much. Assalamu alaikum.